All right, so welcome to today's substance abuse echo. We're thrilled to have you here. As you can see, we are recording. We store this on our Canvas page as well as our YouTube. We use the recordings for educational and quality improvement purposes. You are always free to go back and watch those or share this information with anybody. So know that they are recorded. We'd love to have your participation in Echo. If you feel comfortable, please turn on your cameras, put comments into chat, ask your questions. Kurt Phillips monitors the chat for us, so he would be able to answer any of your questions, as well as all of our hub members, or he'll ask all your questions. He just laughed. I just saw his face when I said he'll answer all of your questions. He'll ask your questions. He might answer them for you as well. So you never know with Kurt what's going to happen. We have an amazing hub team. They will all have an asterisk in front of their name, so you can always reach out to them and ask any questions as well. We do talk about some sensitive topics, so please remember to protect individual privacy, de-identify any information. Again, reach out to hub members if you are unsure about that. Key components of an echo session are always a didactic speaker, and then my favorite part, which is the case presentation and recommendations. It's a great way to get information from everybody on the call about cases that we all come in contact with and how to solve those. So I love the case presentations and hearing all of your guys' answers. It's also a great way to know everybody who's on the call. So perhaps Erica Wall shared something that I want to know about. I know that I can reach out to her and ask for some follow-up. It just builds my professional network. I don't know, Erica, where you're from. Sorry, you're on my screen, so that's why I'm calling on you. But I could, she might be down in southern Utah, and it's going to look a little bit different than what might be up here in northern Utah. So we can just brainstorm and connect with each other on that. If you don't know how to rename your profile, if you'll take a minute and rename your profile, you can do that by clicking the three little dots. Again, it just helps us know where we are all at, what our specialty is, building that professional networking, and who's on the call. Raising your hand is another way that you can participate in it, as well as just putting your information into chat. And as I mentioned, Kurt will make sure that we are answering or following up on those questions. You can always pre-register by emailing projectscope@usu.edu, and that is how we will get you out information. We also will be dropping a chat throughout today's session in chat, the PowerPoints, as well as a survey link. And in order to get a credit of attendance, we do ask that you fill out those surveys. The surveys provide us with information that we then share out with our funders in order to keep these sessions free, and gives us information of how we can also change anything based on what you guys are sharing with us. We do send out a certificate of attendance every month after those surveys have been filled out. Canvas is where we store everything. So if you have not received an invite to Canvas and would like another invite, please email projectscope@USU and put Canvas in the subject line, and we will get you registered on our Canvas page. Case studies are a great way to share information with everybody on the call, as well as learn from everybody on the call. You would be amazed with all the amazing resources that you guys come up with on each case. I know that I've presented cases in the past, and you guys have all come up with things that I've never even thought about doing with the families I work with. So if you have a tough case, or you just have a case that you want to talk about, and make sure that you're doing what you hope is right and get some validation on it, the case presentations are a great way to do that. Sometimes presenting a case can be a little challenging, and we don't always want to do that. But if you have a case and if you would like me to present that for you, please just reach out to us, and we'll be glad to present your case for you so that you don't have to do the talking on that. And they don't always match our didactics. It does not, just because the topic is not on something that is going on with your case, don't worry about that. The case presentations are really a way to just learn from each other and know that where we can get some resources. If you've not followed us on social media, we do share information that is passed on to us as well as about our upcoming sessions. Any information, so if you want to take a minute and follow us on social media. I'm thrilled today to have Taylor from Department of Health and Human Services share with us about her topic today. So I'm going to stop sharing and let Taylor take it away.
Thank you. I'm going to go ahead and share my screen. All right. Can I get some thumbs up to see if...
Yes, we can.
Wonderful, wonderful. All right. Hey, everybody. My name's Taylor Morsillo. I use she, her pronouns. I am a program administrator at the Utah Department of Health and Human Services, specifically in the Office of Substance Use Mental Health. So I oversee state opioid response funding, opioid litigation funding, things like that. My background, I worked in refugee mental health services. I worked in direct substance use care and treatment. I lived for most of my 20s overseas doing HIV treatment and prevention work. So lots of public health implementation. So I'm really thrilled to be here with you all today. I would ask that this be as engaging as possible. I know that we're virtual. Things can get a little uncomfortable or strange. Please use the chat function. For whatever reason, that has disappeared from my screen today. So Janelle, if you see people popping questions in, please let me know. Feel free to interrupt me. Unmute yourself, all the things. So what we're going to talk about today is how our attitudes and perceptions, oh wait, I found my chat. Great, life is good. How our attitudes and perceptions really impact substance use and recovery. So it's going to be a bit of a stigma reduction and awareness training. How our stigma and thoughts and things impact individuals with substance use disorder, mental health issues, access to treatment, things like that. Has anyone taken this training before? I've given it in multiple different spaces. Just curious. Cool. All right, so learning objectives today. I would like us to be able to describe substance use motivations. So like understanding how the chronic disease of substance use disorder originates, develops, things like that. I would like us to be able to, by the end, define stigma, identify its negative effects through that interpersonal systems level and interactions. I want us to be able to recognize strategies to identify and avoid stigma surrounding substance use and substance use disorders. I want us to be able to challenge our negative beliefs about opioid use disorder, medications for opioid use disorder, aka MOUD. And then lastly, we're going to define recovery and talk about its elements, right? Pretty straightforward. So, substance use and misuse. Why do people consume drugs and alcohol? What do we think? Feel free to use the chat. Feel free to unmute yourself.
Enjoyment.
Enjoyment. Yeah, absolutely. Feels good.
Previous trauma.
Trauma. Yeah, we have a chat in here, a way to cope with stress, to dull pain. Absolutely. Really great responses. Thank you, everybody. So yeah, substance use motivations to feel good, the pleasures, the feelings of pleasure, euphoria, sometimes relaxation, energy, sometimes to feel better, like someone was saying, to dull pain, to escape things. It could be a coping mechanism for stress, anxiety, depression, other co-occurring disorders. Another one, social pressure or curiosity, right? Kurt, I don't know if you meant like raised in similar environment, but like, being around substances, being curious why people are engaging. I think that's really relevant for, sort of adolescent, teens, things like that. So origins of substance misuse, I just talked about like why people are motivated to use substances. We're going to dig a little deeper as to like actual reasons that people begin and continue to misuse substances. Someone mentioned trauma, right? Experiencing trauma, especially in childhood, is a major risk factor for substance misuse. We know that mental illness is a risk factor for substance misuse, with more than 1 in 4 adults in the United States living with a serious mental health problem, also having a co-occurring substance use problem. Some people might self-medicate in an attempt to manage distressing symptoms of a mental health disorder or other health condition, chronic pain, things like that. Adverse childhood experiences, I feel like this is a really big buzz term that's used in public health these days. I saw someone nod. So adverse childhood experiences, or ACEs, these are potentially traumatic events that occur in childhood. So that's from 0 to 17 years of age. These are negative things that happen during someone's childhood that can include abuse, neglect, other household challenges like domestic violence, divorce, having a family member who's experiencing incarceration. I also want to bring up some ones that aren't typically talked about. Not having enough food to eat, so food insecurity, experiencing unstable housing or experiencing homelessness, experiencing discrimination, overt and subtle discrimination like racism and things. ACEs put individuals at a risk for a range of health, social, and emotional issues as they age, and they're strongly associated with the development of substance use disorders. We know that with each added ACE, individuals are 2 to 4 times more likely to report early initiation of substance use. We're finding in the research that about 56 to 67% of serious problems associated with substance use are directly correlated to ACEs. We know that those with an ACE score of 5 or more are 7 to 10 times more likely to report illicit drug use, injection drug use, compared to those with an ACE score of 0 to 2. So just things text for why people are utilizing substances, right? So impact of trauma. We know that trauma is a risk factor for substance misuse, and substance misuse is a risk factor for trauma. It's this cyclical, right? There's a direct link between substance use and risky behaviors. People who are already misusing substances may be less able to cope with a traumatic event, and people may develop substance misuse issues to manage distress associated with the effects of a traumatic exposure or traumatic stress symptoms. Tossing a few more statistics out here. In the United States, prior to COVID, because now that we've all lived through COVID pandemic, that is a traumatic event, right? Global pandemic. Prior to that, 70% of all adults in the United States had experienced some form of trauma. Nearly 2/3 of injection drug use can be attributed to abusive and traumatic childhood events. And we were looking at a number around 80% of individuals with a diagnosed opioid use disorder reporting experiencing at least one form of trauma. So kind of sets the stage. I see in the chat here, family history of addiction is also sometimes one of the greatest factors. Absolutely, that goes back to childhood trauma, right? Seeing things, witnessing things. Anyone have thoughts or questions? I just like to set the stage as to like the why people might be engaging in substances, pulling in the trauma component, understanding that it's not a moral failing, right? Give me a little more context. Any thoughts or questions before we charge into this next section? Okay. So this next section is going to be about stigma itself. What is the stigma? We talked about the why. We're going to talk about the what. So Stigma, when I was pulling this training together, I was looking for like a clear definition, right? And there's a lot of historical references. The origin of the word stigma is actually Greek, and it refers to this tattoo or a marking that was burned or branded into the skin of criminals, slaves, traitors, the undesirables of society. The mark was used to designate these people as blemished and to prevent others from associating with them. In a more academic term, we might define stigma as something that is an attribute that is deeply discrediting. It still is associated with social rejection and status loss, though. I like to talk about some components of stigma, right? It helps break things down a bit. First is labeling. So this is when we start noticing and naming differences. A lot of the time, human differences are ignored. Who has curly hair, who has straight hair, how many freckles you have, the length of your toes, things like that. And they're socially irrelevant. Other differences are selected for greater social scrutiny and social consideration. And that's what starts to be seen as socially significant in our society. Substance use behavior is the difference that we're going to discuss throughout this training today. Stereotyping. This is when we start associating those named differences, those labels, with negative traits. A lot of times these associations are automatic. They are, from our systems, from our culture. They serve as a way for humans to make shorthand decisions without having to engage with the complexity of humanity. These associations are used in decision-making. They tend to highlight undesirable traits, right? Then we start to have separation. And this is when labeled people are considered separate. There's an us and a them. The separation starts providing justification for attributing bad characteristics to an entire group of people. At its most extreme, the separation can start leading people to see humans as not really human. They don't deserve the same rights as we assign to others in, quote unquote, our group. Sometimes the labels themselves highlight the separation. So going back to labeling. So you'll hear people say a person has cancer versus a person is bipolar. And so that starts conflating a label with an identity, even though they're both medical diagnoses, right? Next, we have status loss. And this is when we start seeing a lowered placement in the social hierarchy. This starts to impact things like whose opinions are sought out and valued, who has influence. And lastly, we have discrimination, and this is defined as the unfair treatment due to differences. Discrimination can be overt, it can be subtle, it can be on an individual level, and it can be structural, right? All of these components of stigma really depend on the power difference between those who experience stigma and those who perpetuate it. So anyone can engage in labeling, stereotyping, and separating, but it's the power differential that allows for the consequences of status loss and discrimination. So I can stand here in my little home office and say that I think that billionaires are greedy and they're selfish and I don't like them. Cool. I just labeled, I just stereotyped, and I just separated myself from billionaires. My attitude is unlikely to result in any sort of status loss or discrimination of said billionaires because they're in a greater position of power in our society. All right, so this is something to really be mindful of as healthcare professionals, as individuals that are providing treatment, engaging with people that are coming to you looking for support and guidance, right? You have a higher place in the social hierarchy. Another really helpful lens to view stigma through is the perception of fault and control, right? When we think that someone is ill through no fault of their own, or that they have minimal control over their illness, neither the person nor the illness is generally stigmatized. On the other end of that spectrum, if we believe that an illness is within someone's control or is partially their own fault, we tend to attach stigma to the person and the illness. Behavioral health conditions, including substance use disorders, are often viewed in that light, in the latter light. The effect is then compounded if someone is using an illicit substance because there's that added association of criminality, right? I know that I personally have seen communications in the media about opioid use disorder that exemplify this exact point. People will take pains, like social outlets, media outlets will take pains to point out that the first opioids were taken to treat an injury, maybe the doctor overprescribed, it starts reducing the perception of fault, right? Whereas a person who developed a substance use disorder via illicitly obtained substances may be perceived more at fault. So we have this spectrum here, right? Where some people with a condition may be considered more at fault than others. And just to be really, really aware of that and mindful of that. Another helpful way to think about stigma or examine it is to differentiate between internal and external stigma. So internal, we have this like self-stigma or felt stigma. It's the internalization of negative societal perceptions of a stigmatized group or status, right? This can include senses of shame, the expectation of discrimination from others, and that expectation of discrimination, feelings of shame, it can prevent people from seeking help, right? I think a lot about pregnant people that might be engaging in substance use disorder, seeking out prenatal care. The expectation of, feelings of shame and expectation of discrimination and mistreatment from OBGYNs, from providers, might actually prevent them from seeking out care. People that are experiencing the stigma, like have this felt stigma, may use and sometimes deplete all of their emotional regulation strategies to cope. And that can lead to maladaptive coping behaviors, right? So people that are experiencing stigma related to substance use may turn to substance use as a coping mechanism for that self-felt stigma. We know that this felt stigma, perceived stigma, is associated with lower self-esteem, higher rates of depression and anxiety, and poor sleep. The other end of the spectrum is external stigma. And so this is experienced stigma, right? It takes the form of discrimination towards a stigmatized person. This discrimination can be on an individual level, like person to person, rejecting a job application, refusing to rent someone an apartment, open a bank account, things like that. That individual level discrimination can be tied to a specific behavior, a specific moment in time, right? We also have structural discrimination, and that starts encompassing the disadvantage that arises out of that individual interpersonal model, right? Institutional practices, policies, laws, regulations can exacerbate those disadvantages. I provide an example here, is stigma against people who have experienced an overdose and who have been revived by naloxone. There are individual attitudes of discrimination, right? Someone can sit there and say that they don't think someone deserves to be revived from an overdose. That's a personal opinion, right? That's that external individual level. But then if you extrapolate that into an institutional practice, right, on a structural discrimination level, this would be something like police departments refusing to carry naloxone, right? So questions or thoughts about stigma itself? I like to break it down into its various components, how we can think about it. So we talked about the why, we talked about the what, and we're going to jump into the how now. All right, Bueller. So stigma and language. Language use is really, really important. When I talk about potentially stigmatizing language, I would like to just, make a big caveat statement here. I want to differentiate between intention and potential impact, right? So stigma, we know, can be perpetuated through the language that we use to talk about substance use disorders. Many times, the words that we use are inherited. They may be very commonly used in the settings that we find ourselves with the people that we're working with, right? So please give yourself a little bit of grace and compassion and understanding. Using the words that have been inherited, that have been taught to us, does not mean that we have bad intention. But knowing that the impact of potentially stigmatizing language exists, it can give us an opportunity to choose another path, right? We have evidence that shows that using stigmatizing and negative language to describe people can have negative impacts on their health. So one strategy we can do and engage with to identify and avoid stigma is to perform a language audit. We can start thinking about the language that we use in our speech every day, in our writing, and we can consider alternatives to that potentially stigmatizing language. One way to do that is to use person-first language. This is a really simple and yet so impactful a strategy, right? So this is a linguistic prescription that puts a person before the diagnosis. It describes what condition a person has rather than asserting what a person is. Going back to that labeling, right? A person has cancer versus a person is bipolar. If you call someone a druggie, a junkie, or an addict, you're implying that the person is the problem. You're labeling them. You're connecting them to stereotypes. Rather than using labels to define individuals with a complex health issue, it's much more appropriate to use terminology that describes individuals as being diagnosed with an illness or a disorder. Again, person-first language or people-first language, it puts the person before the diagnosis. It describes what a person has, not what a person is. So if you say that someone has a substance use disorder or someone has a substance addiction, it implies that the person has a problem, a health problem that can be addressed and treated, right? Another type of audit and thing that we can be mindful of is using clear and technical language. Clear and technical language has a single clear meaning. It can help avoid stigma and confusion. Oh gosh, wrong slide, sorry. When describing, a good example I like to use here is describing the results of a urine drug screen, right? Some people tend to use the words dirty or clean. It's a medical test, right? It's positive or negative. When we use words like dirty and clean, that conflates someone's drug use status with their cleanliness. A much more accurate technical language to use, less value-laden words to use would be positive or negative, the same you would with any other medical test result. So common examples, right? She abuses pills. We know that abuse is a negative, harmful behavior, associated with immoral behaviors. He's an addict. This word addict, it demonizes and it depersonalizes a patient or a client. So on the left here, we have some common terminology. Some of these words, like I said, are incredibly common. Let's be kind to ourselves here. A lot of these are inherited. A lot of these are maybe used by your patients, your clients themselves, right? If people are choosing to describe themselves as this, that is fine. Taking on the label of addict sometimes is very important to people in like mutual group and aid settings because they see that as a label that is a constant reminder of their recovery journey. As healthcare professionals, though, we can choose less value-laden terms when we describe people with substance use disorders. So on the right-hand side here, I have some general thoughts, some language suggestions that are intended to switch the language around substance use disorder to align much more closely with language that we would use to describe other chronic illnesses. So a big one for me is relapse. Recurrence or return to use is a much less value-laden term, right? Again, calling someone an addict implies that they are the problem. Stating that someone has a substance use disorder implies that they have a health issue that can be addressed. Substance abuse, again, the word abuse, really negative. Substance misuse, substance use disorder. Someone is in denial. That is a very provider-centric way to state things. They might be ambivalent to their treatment, right? Relapse prevention, I like to call it recovery management. Clean and sober, they're drug-free. Again, it goes back to conflating drug use status with someone's cleanliness. Yes, words really matter. And then resistant to treatment. I like to point out that that is, it's a medically valid term, right? We use that in charting and things, but that evokes a provider-centric worldview. Choosing not to is much less value-laden. It provides patient autonomy, helps us understand that, individuals have their own lives. And if if a treatment program is not working for them, we need to figure out what's going on and adapt. So yeah, just the alternative terminology really reinforces the patient-centered perspective. It values an individual's autonomy, their decision-making, where their life is like, or where it's at. All right, I have a quick exercise. I promise it is painless. I'm going to pop 5 sentences, well, one at a time, up on the screen. We are going to take a moment to identify the language, decide if it is stigmatizing, and if so, why it might be stigmatizing. Maybe they are, maybe they aren't. And then if it is, I would love a suggested reword to replace stigmatizing languages. So first one, Paul is a substance abuser. Is this stigmatizing? Yes. Cool. Yes, it is. What about it is stigmatizing, and how can we reword it? Feel free to unmute. Would love to chat. Also, chat function is perfectly fine.
So the abuser part is what is stigmatizing in my mind.
Absolutely. It's negative. It's associated with harmful behaviors. It has that immoral association, right? It implies that he is the problem, right? How can we reword this to be less stigmatizing and clear? Paul is misusing substances. Sure. Paul has a substance use disorder. But yeah, great. Thank you. All right, next one. Rachel's drug of abuse is cocaine. Is this stigmatizing?
Yes.
Yeah, absolutely. Is there something, what about this is stigmatizing? What's the language in here?
Again,
Abuse. Yeah,
putting it on Rachel, like that she's the bad person because she uses cocaine.
right. Again, that immoral association. How can we reword this to still get the message across in a less stigmatizing way?
Rachel misuses cocaine.
Yeah, Denise popped it in the chat. Rachel uses cocaine. Boom. Simple, clear, to the point. We don't have to add, use, abuse, anything like that. She uses cocaine. Very simple. All right. Number 3, Kathleen has been clean and sober for over a year. First of all, shout out to Kathleen. You go, girl. Is this stigmatizing? Yes. And Denise popped it in there. The word clean, right? So it's conflating Kathleen's drug use or lack of drug use to her cleanliness, right? It conflates drug use status with a person's cleanliness. How can it, while intended to be a compliment and like a celebratory statement, it still is stigmatizing, right? It's reinforcing that stigma surrounding people who are using substances. How can we, yeah, Elaine nailed it on the head. Thank you, Elaine, in the chat. Kathleen has not used drugs for over a year. Exactly. Kathleen has not used drugs. Boom, simple, to the point. Wonderful. Thank you. Number 4, Brian is non-compliant with his treatment plan. Dang it, Brian. Is this stigmatizing? Yes. Yes, we got some yeses in here. What about it could potentially be stigmatizing? Non-compliant? Thanks, Elaine. Yeah, absolutely. So again, like to go back to, as clinicians, as healthcare providers, the term non-compliant is in medical documentation. It can be utilized when speaking to other clinicians, healthcare providers, things like that. It's a medically reasonable term. I would like to acquiesce to that. I do want to encourage us to be careful about when using with patients, clients. It can cause the patient to feel unmotivated, right? So how can we reword this? Brian is choosing not to engage in his treatment plan at this time. Miles nailed it on the head. Beautiful. Something like Brian has not been attending his treatment appointments. Brian is choosing not to follow his treatment plan. Brian's treatment plan isn't working for him, right? So it puts the onus on us as the healthcare professionals, as the clinicians, right? To be mindful, to figure out why is this not working? Brian is like, when we say Brian is non-compliant, it means Brian's not following our directions. We know better. We don't. We aren't Brian. We don't live Brian's life. We don't know what his day-to-day is, right? So being mindful of that, again, person first treatment is really important. All right, very last one. Sally keeps providing, oh, we need to find a different treatment plan or treatment for Brian. Great, thanks, Maria, absolutely. Sally keeps providing dirty urine for her drug screens. Dang it, Sally. Is this stigmatizing? Yes, dirty, exactly. Going back to that, conflating drug use status to a person's cleanliness. How can we reword this to be clear technical language when describing a medical test? Sally has a negative. Sally's, yeah, this was talking about testing positive, right? So Sally's urine tested positive. Sally's urine tests are positive. Yeah, Sally's urine drug screens have come back positive. Knew what you meant, Denise. Yeah, absolutely. Yes, exactly. Describing a UDS as positive or negative, just like we do for every other medical test, right? All right, thank you, everybody. The hard part's over. The exercise is done. I appreciate your participation.
Taylor, this is Janelle. I just think that, I mean, that was just such a powerful thing to think about it in terms of just words, that words matter. I mean, for another echo session, we just had one on suicide prevention and talk, that's that same concept, right? Like the positive, not the positive, but the correct words around suicide. Same thing with around substance abuse. Those words matter. So that was really powerful. Thank you.
Yeah, absolutely. The word abuse, it just like it sticks so wrong with me now. I've given this training so many times. Um, and yeah, I think being very cognizant of the language that we have inherited. Again, like it's an opportunity for us to start the unlearning process, to think about what alternative terminologies are and to align language that is used with other chronic illnesses with substance use disorder, I think is a great place to start. And if anyone wants to provide this training to other spaces or would like this training in different spaces, please let me know. Happy to provide it. So there are two more types of communication that I want to just touch on that can also be impactful, right? So the first is nonverbal communication. It's a really good strategy for recognizing and avoiding stigma is to note and pay attention to our nonverbal communication. We know that nonverbal communication can represent up to 2/3 of how we interact, right? Of our communication. This can be our tone, our posture, our face and body movements like eye contact, our vocal tone, and even physical proximity, right? So if I know that we're in a virtual space, but if I were speaking just in a monotone voice and just like not really engaging and wasn't moving around, and this is how I was presenting this training, would that be impactful? Hopefully not, maybe. But same thing, if you're a provider and you're in an operatory with a client, right? You're in the room, if you're standing there against the wall with your arms crossed and you're giving them the up down and you're speaking in a really discouraging tone and there's a lot of judgment and even some sass in your voice, is that client going to continue to come back and seek treatment, seek help, feel comfortable asking questions, needed medical interventions? Probably not. But if you were standing there, engaging, arms open, using encouraging vocal tones, that has positive impact on a patient's health outcome. They might come to see you again, like, oh, this person didn't judge me. Oh, this is a safe space to talk about why I'm misusing substances, how I can get treatment, what I need, right? So being aware of our nonverbal communication is really important. The last one, visual portrayals. It might not come up as frequently in your work, but I think it's really worth mentioning our visual portrayals of people with substance use disorder. I know that I have seen media coverage of people who have experienced an overdose. Police departments often share clear photos of people with the media, right? So even without verbal commentary, the sharing of these images sends a clear message that the privacy of people who have experienced an overdose is not a priority, right? It designates them as the other, not deserving as the same rights as us. This type of nonverbal communication can have tremendous negative impact, and it continues to compound that internal and external stigma. So I encourage you all to be on the lookout for negative visual portrayals of people with substance use disorder, either in media or in advertising. And it's something to keep in mind if you yourself are developing any sort of literature, like patient brochures, things like that. An image portrays a moment in time. Sometimes those images are staged. You know, if we go to the Adobe stock photos and you type in heroin use, and it's like, oh my goodness, the photos that pop up are unreal. So sometimes those are staged, right? Others are real life. Either way, it's an incomplete depiction of the subject, of what has happened, the context of what has led a person to this moment, right? So just please be mindful of visual portrayals. Be on the lookout for things in your community. Any thoughts, questions, comments, or concerns about language and substance use disorder? All right. If you do, please pop them in the chat or unmute. Happy to answer. So, two more sections here. This one should be pretty short, sweet. I just want to address what medications for opioid use disorder, MOUD, are, and dispel some of the myths and misconceptions surrounding it. This might be a review to some, so, and if it is, cool. And if it's not, if you have some questions or concerns, let me know. So, MOUD, medications for opioid use disorder. It is FDA-approved medications, sometimes in combination with counseling and other behavioral therapies, but MOUD is specifically the medications. Goals of MOUD, goals of the medications themselves. Stabilize abnormal brain activity. And we can get into all of that at another time if you want to. Reduce cravings and strengthen a person's coping capacity. These medications allow patients to focus on behavioral therapies if they choose to. We start seeing increased periods of abstinence and self-efficacy, and we start seeing improved clinical outcomes for clients and reducing impact on family and loved ones, right? So, first statement that I hear pretty often, MOUD replaces one addiction with another. How many people have heard this before? You know, talking about Suboxone, getting on methadone, using buprenorphine, right? Just replacing one addiction with another. Have people heard this before?
I have.
Yeah, absolutely. It's a common one, right? Yeah. So when we hear that, we can dispel that with some science. First, we can give them the definition of an addiction, that we know that it is a chronic illness, a chronic disease that is composed of complex interactions of someone's brain circuits, their genetics, the environment, and their life experiences, right? Going back to ACEs, going back to inherited trauma, going back to what our parents, what our environments are, things like that. It is the repeated use of substances despite negative effects on mental health, on physical health, interpersonal relationships. Taking a medication that is prescribed to you by your doctor to treat a chronic illness doesn't meet that definition, right? We know that some of the medications like methadone and buprenorphine, they have gradual mechanisms of action. They stabilize that brain chemistry without producing euphoria or leading to a crash. We know that naltrexone blocks opioid receptors. It's often used in, the prevention of a return to use. But we know that all three medications help to reduce cravings and the euphoric effects of opioids. So taking a medication prescribed to you by your doctor to treat a chronic illness does not line up with engaging in behaviors that are compulsive and would continue despite harmful consequences, right? Myth dispelled. Next, I hear this one sometimes too. Medically supervised withdrawal, aka detox, is a form of treatment. Yeah, get them to the detox center, 28 days, we're good, right? Is that how that works? Yeah. We know, or like it's the detox is better than MOUD, right? Or in lieu of. We know that there is no evidence that detox programs are effective at treating opioid use disorder. Detox alone is not a treatment for opioid use disorder. It actually increases an individual's risk for return to use and overdose, potential death, when it's not followed with medications for opioid use disorder. Medically supervised withdrawal or detox can be a first step in addiction treatment, right? But without follow-up treatment medications after that detoxification process, patients, clients are likely to start using substances again. And again, without follow-up treatment, when someone has detoxified from a substance, it can increase their chance of overdose because it's lowered a person's tolerance. Next one, MOUD is only intended for short-term treatment, right? Those 28-day programs, get them in, get them out. Absolutely not. There is no one-size-fits-all approach to treatment length. Actually, according to NIDA, they found that the length of methadone treatment should be a minimum of 12 months. Some patients we know require long-term maintenance. You know, I approach this similar to how we would heart disease or diabetes, right? We don't just give someone some insulin for a year and they're good. Set them off, you're good. We know that opioid use disorder is a chronic illness. It has a chronic nature. So the need for continuing medications should be reevaluated periodically. There is no maximum recommendation for the duration of maintenance treatment. And for some patients, treatment may continue indefinitely, right? MOUD is not effective because it doesn't immediately end drug addiction. I hear this from time to time, right? Like, well, when are people going to be cured? Well, if we think about going back to what the goals of MOUD are, there was nothing in that list that said curing, right? These medications are not intended to cure opioid use disorder. Substance use disorders, addictions, opioid use disorder, it's a chronic illness that impacts individuals for their entire lifetime. Medications for opioid use disorder, MOUD, reduces cravings. It increases person's engagement in treatment, right? And it reduces the chance of an opioid overdose. The medications manage the physiological aspects of an addiction. Medical treatment for addiction, it should be compared to medical treatment for other chronic conditions, like I was saying, diabetes, high blood pressure. Just as diabetes isn't cured by the use of insulin, and people with high blood pressure often continue taking medications for many years, opioid use disorders are not cured, but instead well managed with medications for opioid use disorder, right? Another one that I hear pretty often is, you know, MOUD is inferior to complete unassisted abstinence. We should be tapering people, they should be sober, right? That type of thing. So while some people do taper off of the medications, most patients go through many dangerous cycles of return to use and recovery. MOUD can make the recovery process much safer and has saved many lives by preventing deaths from overdose, right? Substance use disorders, we know, can be treated and managed with medications and counseling, much like other medical conditions. We know that MOUD is so much more effective than treatment approaches that focus on complete unassisted abstinence. Honestly, this is a personal opinion. Abstinence treatments often demonize any sort of return to use. They make people in recovery, trying to find recovery journey, feel like failures if there is a return to use. And that just perpetuates stigma that's associated with substance use disorder, right? So by treating and managing substance use disorders with medications like other medical conditions is going to be just so much more beneficial than like focusing on abstinence. Okay, those are some of the big myths and misconceptions that I hear pretty often about MOUD. Sometimes I like to talk about harm reduction as well and safe injection points, things like that, that also have a lot of stigma associated with them. Happy to go into that with people if they're interested offline. But any thoughts or questions or comments or concerns about the myths and misconceptions surrounding medications for opioid use disorder? Okay. So last section here, and then give you back your afternoon. Defining recovery. So my question for you all, how do you define recovery? Feel free to unmute, pop it in the chat. I want to know what people's definitions of recovery are. Lifelong battle. Yeah. Ongoing support. Anybody else have thoughts on how they define recovery? Healthy management, back to work, safe to be around, feeling in control, able to return to lives in a healthy way. Beautiful. Regaining control. Love all of this. A process of healing. Gorgeous. Thank you all for that participation. Really appreciate it. I love to see how people define recovery. We have an ongoing journey or struggle of healing and not returning to use. Beautiful. Absolutely. We notice that every single person that pops something in the chat here has a different definition of recovery. Keep that in mind. This is my definition. I define recovery as a process of change through which individuals improve their health and wellness, they live a self-directed life, and they strive to reach their full potential. So my definition is a little different than Erica's and Maria's and Vanessa's, right? Which goes to show that maybe our patients, our clients have different definitions of recovery. Recovery looks different for everybody. Going back to that, there's no one size fits all that fits a treatment approach. There's no one size fits all recovery for what it looks like. It's going to be dependent upon everybody. I also would like to point out that in my definition of recovery, there's nothing about abstinence from substances. There's nothing about abstinence from medication. It's focusing on the person and how they can live a self-directed life and reach what they feel is their full potential, right? There are some common elements of recovery that I like to highlight. The first is treating addiction as a chronic disease that we know can enter a stage of remission, right? Understanding that complete abstinence may not be a realistic goal for everyone. You know, individuals that have misused alcohol in the past, they might be able to engage safely with something like marijuana, right? Or vice versa. You know, individuals that have misused heroin in the past may feel comfortable having some beers or some wine, that type of thing. Understanding that recovery and viewing it as a lifelong journey gives space to understand that there might be cycles of recurrence and remission, just like there might be with diabetes, with heart issues, with cancer, other chronic illnesses, right? But if we take a moment to address whole person wellness beyond simple substance use behaviors or patterns, and that, you know, sobriety or abstinence is not the end goal, I think that that's really, really important. So I do want to talk for a moment about a recurrence of use. How a return to substance use is framed is really important. We should all understand that it should be an expected part of the recovery process, right? But how we frame it as healthcare providers, clinicians, it can really affect patients. If we frame it as a failure, obviously it's demoralizing. It can reinforce that internalized stigma, that felt stigma, right? And may reduce people, discourage people from coming to seek out help. A return to use is not a moral failing of our clients or patients. They're not a lost cause, right? No one treatment plan will work for patients with a substance use disorder. We need to replace the term relapse with return to use or return to substance use. And then we need to think about our treatment recommendations, right? Based on patients' concerns, just as when treating any other chronic illness. So if someone is unable to maintain recovery with the current treatment plan, that's on us to think about, do they need a referral to more intensive treatments? Do they need additional recovery supports, a different medication, all of the above, right? So community resources, I just like to pop this in here. We have Utah naloxone. It's wonderful. They focus on end user trainings. They'll give kits to anybody that attends a training. We have medication disposal kiosks around the state. Sorry, I'll just click through that real quick. So key points. Last slide. except for the references slide. If we take nothing away from the training today of me talking at you for about an hour, I hope that these points stick with you. So first one, stigma. It can be internal or external. Either way, it has measurable negative impacts on a person's health. We have strong evidence to address a lot of the stigma-laden misconceptions surrounding medications for opioid use disorder. Hopefully, we have some strategies in our back pocket now for recognizing and avoiding stigma, like a language audit, increasing your awareness of nonverbal communication, visual portrayals, things like that. And then understanding that recovery is a process of pursuing health and wellness rather than a destination defined solely by abstinence. Hopefully that can help reduce the stigma surrounding recurrence of use. Opening up for any questions or concerns. If people want some of the literature, I have all of my references available. But
Taylor, can I ask questions? This is Kurt.
hi, Kurt.
I like what you said about that the end goal may not be total absence, right? Any addiction that's a heavy addiction is going to end up in relapse. And you talked about the guilt and all that kind of stuff, failure that goes on. What do you do when you have somebody come that says, I want to get totally off. I just want to be totally clean, right? I want to be totally away from drugs. I want abstinence. That's my goal.
Yeah, that's wonderful.
Is that something you go ahead and support that, just helping inform them that you may have some times when you actually use again, and that's okay, and we'll just continue to work. I mean, because it sounded, I didn't want to put words in your mouth, but it sounded like we don't want to necessarily set our bar at total absence. We want to set our bar here, and if they want to work toward total absence, we're good with that. Is that, I don't want to put words in your mouth. I just wanted to get a clarification on that.
That's not putting words in my mouth at all. I think that's a really lovely question. If someone's goal, right, I appreciate the fact that you're invoking a patient-centered perspective, right? If you have a patient or client that's coming to you saying, I want to achieve sobriety, I want to be abstinent from all substances, I don't need them in my life, then that is our goal as the provider, as the healthcare professional, to encourage that, to figure out ways, a treatment plan that could help them achieve that goal, right? If that is how they want to live their self-directed life, if that's how they feel that they can reach their best potential, we should support that, right? And so then that looks at, okay, realistically, if you're using this much of a substance, right? Let's taper you through medications. It's going to be a slow taper. We're going to need to check in periodically to see how you're feeling. Have your cravings come back? How are you doing with your emotional states? Things like that. If people want their end goal to be abstinence, we support that, right? My statements is that might not be a realistic goal for everyone, and to keep that in mind. Like some people might be on buprenorphine or Suboxone indefinitely, right? Just like some individuals are on insulin forever or Wellbutrin, right? It's treating substance use disorder as a chronic illness rather than something that needs to be cured, right? Great question. I really appreciate that.
Thank you. I appreciate the answer.
Yeah. Anybody else have questions or concerns? Comments on this?
Again, I think it was super helpful to reframe our thinking about that. I mean, I just think a lot of us work with young children and their parents are the substance abuse users. And so understanding that perspective of how do we help the parents as we're also helping support the child within our efforts. That was just, I thought, really helpful.
Yeah, it was.
Lori, it looks like she has her hand raised.
Hi, Lori.
Hi. So I just kind of have a question, what your thoughts are on like methadone clinics and Suboxone clinics, because I'm in Montana and I have a friend that was involved in a methadone clinic, and they have such a brief, I was a former drug alcohol counselor too many years ago, but in these clinics, they seem to just go in, they see a counselor for 5-10 minutes, and then they get their prescription. So in my friend's case, she came out of the methadone clinic taking more methadone than she did before she entered and was taking it off the streets. So what do you think about that, you know, that balance, that it's not really in her case, it seemed to have made things much worse, because then she was selling her methadone on the street, and then she was getting money back, and then she's going to the clinic on her appointments, and her brief interactions with a counselor were literally 5-10 minutes. I mean, there wasn't like an in-depth counseling process or therapeutic process.
Yeah. I have two follow-up questions, or a follow-up question before responding to that, or just like a statement. So methadone clinics are like OTPs, right? They're regulated by the state, by your state SOTA, and there's specific guidelines and things. People can't take methadone out of the clinic. It is something that you have to ingest while you're there. So perhaps this was like Suboxone or buprenorphine.
No, she actually was able to get a release, because this about her clinic is 2.5 hours away from our hometown.
Gotcha.
So she was able to get more than, if she
the take home dosage. Yes.
Right.
Yes.
And so in the beginning it was great, but then of course her addictive brain and just her addiction in general, it kind of took off down that road. Sure. Where she kind of was making money, connecting with more friends.
Right. And the risk of diversion exists with any sort of substance, right? The opportunity to potentially make some money or help individuals treat their withdrawal symptoms. When we see individuals misusing prescriptions or diverting their prescriptions, and who is engaging with those diverted products, oftentimes it is to manage their own withdrawal symptoms, right? When someone reaches a specific stage of their addiction, of their substance use disorder, oftentimes people aren't continuing to use to feel that euphoria, to achieve that high, right? It's to manage not feeling like crap. It's to manage all the withdrawal symptoms. Exactly. So, and then I think that speaks to the barriers. If your friend had to travel so far to get treatment, like I understand the reason that things were being diverted in the hometown, right? But barriers, access to transportation, to care, all of those exist, right? So that's my thought to like the diversion component. The questions surrounding the brief engagement, potentially like not the best screening or intake component, right? Where things were again overprescribed. That's going to be on like a provider to provider basis, right? We have programs like academic detailing that work with providers to check controlled substance databases, to monitor prescribers, like that's what the DEA does as well, right? To ensure that there isn't this overprescription, things like that. That's going to be more on the providers there themselves that are performing the screenings, doing an appropriate assessment and intake form. So I'm really sorry to hear that happened where there was the overprescription. That's frustrating, right? I think that's just a larger systematic failing, and not so much like a stigma and whatnot component.
Thank you.
I don't know if that was a helpful answer at all.
Yeah, well, it is, because I just didn't know, every state's different. And in my personal opinion, I had a lot of issues with it, because I didn't see it helping her, and I could see her, like I said, she's trying to help her friends out, and then she's, it just seemed like the triggers just kept going, and then she was like doing 13-stepping, she's meeting more people, and it just became where the methadone clinic was not so much a helpful tool for her as it was almost a place for her to hook up with more drugs and more people and more dealers in a sense. Yeah. So I just wasn't sure if it was kind of just that town. I don't want to go into details, but in Montana, if that was just a poorly run clinic, or if that's...
It could have been, right? And I don't want to stigmatize clinics, right? Because they are often overworked and underpaid type spaces. I dropped a link in the chat here about state opioid treatment authorities. And so each state has a SOTA, their state opioid treatment authority person. So like mine is my supervisor. Here's in Utah, ours is my supervisor, Veronica Little, right? This is someone that if you're ever suspecting spaces are overprescribing, or you have questions, especially methadone clinics, I would encourage you to reach out to your state SOTA and express some concerns, some questions. They can reach out, they can do a follow-up. There's quality assurance programs that are built and designed for this to help regulate. Yeah, that would be my primary space to start. And if there needs to be a larger space, like, DEA involvement because of a prescriber overprescribing, things like that. That looks much larger for a shutdown. So great question. Thanks for bringing that up, Lori.
Thank you.
Well, great. Taylor, I can't thank you enough for sharing with us again. I am gonna, if you have any questions, please reach out to Taylor. I'm sure she would be glad to answer any questions or route it through us, and we'll get those questions to her. I am gonna turn the time over to Kurt. He is the one who is presenting our case today on a cute little family that he works with, I think.
Everybody, I appreciate your time.
Thank you.
Okay, so I'll finish up the technology here, get myself unmuted. As Janelle says, you never know what's going to happen when I'm on here, but I just want to share with you a little bit about a family that I'm working with and maybe get some ideas. I'll run through this pretty quick so we can get into those breakout groups. Let me see. Are you guys seeing the right mode now with the slides?
Yes, great. Thank you.
Perfect. All right. So just for me, I've been a physical therapist for about 25 years, been working in the Part C early intervention program here in Northern Utah for that amount of time. I've had an interesting revelation, so to speak, of things that go on with these kids that are born exposed to substances over the past few years. As we've done these substance abuse echoes, it's educated me a lot, and I'm hoping to get some information for how to help this family. Typically, I'm in the home with my visits. Sometimes I do them virtually. With this family, I'm always in the home because the kid's pretty young and the parents need some support. I've changed the name. His name's not really Bruce, but anyways, we'll call him Bruce. So he's a 3-month-old boy who's in foster care. He came in through DCFS. He was exposed to multiple substances prior to birth, including meth and marijuana. He was put in DCFS care at or around the time he was born. No family was able to care for him, so he was put in the foster care system with this couple that now are his foster parents. He does have one older sister that's with him in the home. She's about 3 years old, give or take. I'm not sure exactly on her age. He hasn't had any real contact with birth parents that I know of since beginning the foster care and getting out of the hospital. Mom and dad are a younger couple. They don't have any kids of their own, but they do have, every time I go, they say they have their dog babies. So these are larger dogs, but they're really gentle. They love the kids. The kids seem to respond really well to him. They've been foster parents for several years, had many placements with them, so they're experienced foster parents. They live in an apartment. Both of them work, but they kind of work opposite shifts. Mom only works part-time. Last time I was there, dad was there. Most of the time, mom's there. So the primary concern for this little kiddo is that he cries nonstop. And mom said that it was worse before when he was in the withdrawal part of his life, when he came out of the hospital on the withdrawal from the substance, but that he still cries a lot, still super fussy, difficult to get any time where he's not crying is how she describes it. She's not sure how to handle that because the typical soothing techniques, which she describes as holding, rocking, patting, engaging, trying to play with them, just don't seem to work like they have with some of the other foster kids she's had that have maybe had a little bit of a difficult start. Mom and dad are getting pretty frustrated and stressed because they have a lack of sleep. And anybody who has kids knows that when the kids don't sleep, typically mom doesn't sleep or dad doesn't sleep. And so that lack of sleep can lead to that frustration and just stress. You add on to that the fact that they both work and are on opposite schedules, so don't have a lot of time to spend together. But when they do, it seems like all they're doing is taking care of this little kiddo. He's eating okay, but the foster mom's worried because he is pretty small. There hasn't been anything from his primary care physician, the pediatrician, that would say that there's an issue with weight, but he's quite a bit smaller than what mom thinks he should be. So she's worried about his eating, worried about his nutrition. So that's just another stressor to tack on top. As far as the goals, as I've talked to this family, the main goal is how to get him to calm down more quickly and for a longer period of time. So when they can get him to calm down and stop crying, it seems like it's a short time, and then any little thing can trigger. Maybe it's a sound outside. Maybe it's, the dog coming and he didn't expect that, he startles, and then he goes into this crying and he can't calm himself. Other things they talk often about, that they wish they had family that lived nearby, because they just don't have really any friends that they can leave the kids with, don't have any family. And so that support, they're constantly caring for this little boy and his sister. And then also the goal of making sure that he's getting enough food and eating enough so that he will grow and not be quite so small. And he's not, I don't think he's small lengthwise. He's a skinny little kid is what it is. Barriers that we see is mom and dad both work, so time is scarce for them to do a lot of appointments or other things. Baby does have a difficult sleep schedule. There's not, I guess I should say schedule, use it loosely. There's not really a schedule. He sleeps when he's just so tired he can't stay awake anymore, is how they describe it. And then mom and dad don't have any real support from family. No one lives close, don't have any close friends. So those are kind of the goals and the barriers that we see. And so what I would love to have some input on is any type of soothing or calming techniques that might help him or might work for helping him stop crying, and would be able to work for a little bit longer period of time, so mom and dad can have some time off from the crying. How do mom and dad, with the limited time and resources, how do they de-stress? How do they ever find time to spend together as a couple without having to have one of them taking care of the kid? And then also, what can be done to ease mom's fears about her child being undernourished? Because even though her doctor says he's decent on the weight scale, mom still is hesitant to believe that. She just thinks he's too skinny. So that's the situation. So those are the things, if we've got any help we can have, that would be great.
Great. So Kurt will be jumping in and out of breakout groups today. Natalie, you're going to be in charge of one group, and you will be talking about the different types of soothing, calming techniques that might help him. And then Lisa, you are going to be taking the next two, which is how to help mom and dad with limited time and resources, and what can be done to help mom's fears about being undernourished. And we'll go in there for about 15 minutes and then we'll come back.